The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone. This is Robbie Miller, Executive Director of Axis, welcoming you to an Axis webinar with the title of The State of Fertility in X and Y Chromosome Variation Individuals, What You Should Know in 2018. We're pleased that you could join us tonight, and we have two very distinguished speakers, Dr. Hooman Sadri and Dr. Stanley Kogan. Before I introduce you to them, I want to first of all thank two of our sponsors, Endo Pharmaceuticals and Roche Diagnostics Corporation, who have generously supported the Axis webinar series for 2017-2018. And I'd also like to have our webinar manager, Rick, tell you a few things about the logistics here tonight of the webinar so that you'll be able to ask questions. Rick, anything that you can say that would be helpful here?
Hi, everyone. Welcome to the webinar. I would just like to say at any time during the webinar, you can ask a question. If you look at your GoToWebinar control panel, you'll see a text box under questions, and you can enter your question right in there and hit send. And the doctors and Robbie will be able to see that, and we can get to those at the end of the presentation. All right, thanks.
Thank you. Okay, Dr. Sadri and Dr. Kogan, I'm going to turn this over to you, and maybe you could tell us a little bit about yourselves.
Sure. Good evening, everyone. This is Hooman Sadri. I'm a faculty at University in North Carolina, Wake Forest University in Winston-Salem, North Carolina. I'm a physician in the field of male infertility since almost 18 years ago. And I enjoyed actually working with many couples and individuals, which I was able to help them to pass the infertility problem. And in my career, actually, because in addition to my medical practice, I was involved as a CEO of one of the largest infertility centers, actually worldwide. I had a chance to learn about other specialty related to infertility, including male, female embryology, other lab people, and I'm sure that actually was great for me to learn and helped me to help my patients in this way. Currently, I'm practicing as a urology physician at Wake Forest Baptist, and also I'm running a research group which we are trying to find new, actually, therapeutic tools and novel treatment to help more patients dealing with infertility. Of course, my main focus as a specialist it's on male, but I'm working very closely with the female specialists, and because we know that there are questions about the male and females with X and Y variation, we will try to provide information tonight as much as we can for both groups. That's great to be with you, and I appreciate Axis, which I feel that I'm part of this society right now, this association, and I hope I can help everyone to understand and get what they're looking for themselves, or I know their children who are dealing with this. Thank you.
Good evening, everyone. This is Dr. Stanley Kogan talking. I am a pediatric urological surgeon of over 40 years of practice, and a few years back I decided that I needed to involve myself further in the research side of a lifelong professional interest which I have had, which is issues regarding fertility problems in children. So I gave up my clinical practice in New York and came to work with Dr. Sadri at the Institute for Regenerative Medicine a research institute here in Winston-Salem, North Carolina. And he and I are part of a team that collaborate on both the research and the clinical aspects of problems of this nature. So what exactly does that mean? Fertility problems in children that I've worked with include children with various genital disorders, those with testicular and ovarian disorders, children with hormonal imbalances that cause them to be infertile, and those, of course, that have genetic disorders predisposing to infertility later in life. So I'm very delighted to have the opportunity provided by the Access Foundation to be able to be a part of this webinar, and I hope what we present to you tonight is helpful. Thank you.
Okay. Thank you, Dr. Kogan. Robbie, can I start?
Absolutely. It's all,
Sure.
you know, the stage is yours.
Good, thank you. Tonight, actually, this is our objectives that we are going to discuss about it. You know, we will present in more classic way. I wish we had a chance that we could actually talk directly, but of course, technology allows us at least to be connected from everywhere. But we are going to actually follow these objectives, and then at the end, of course, we would like to answer the question that's still remaining, or it's about the specific cases. Our focus will be about X and Y variation, but it's good to know initially how much infertility involves the whole population, either in male or female, because then we understand what will be the difference in the people with the X and Y variation. And of course, after that, we will talk about the X and Y variation in male, which the Klinefelter syndrome, it's the most common, and we will focus on that aspect. And then we move to triple X for the females. And for all of these patients, we will discuss about the current clinical options that are available to treat infertility. And we will talk also a little about what we expect in the future, in addition to what is available today. It's very important to understand that, and I'm sure many of you know that, when we are talking about reproduction, we cannot talk and point just 1%. It's the male and the female. And that's why we need at least two specialty focused on any of these problems: the gynecologist, and mainly the specialist in this field that they are focused and subspecialized on female fertility. In the other hand, we have mainly urologists, which a kind of newer word, it's andrology, which is a subspecialty that's focused on male fertility. And of course, you know, working on both of these together, it's a reproductive medicine which covers male and female both, and it's always important to work as a team, not as an individual physician, to help a couple to achieve their goals, which we are going to talk about it. There's some terminology that we will use tonight, and also in this field, it's good to understand, because especially when you are reading some text or you hear about this kind of things, it's nice to know the definition of every main terminology in this field. Of course, fertility means the ability to conceive or induce pregnancy in general. And when a pregnancy happens, not always will be ended to a live birth. And if there is the ability to do, then we call it fecundity. And of course, when the fertility has some problem, we talk about infertility. But when we can call someone is dealing with infertility, based on the definition accepted by World Health Organization, WHO, at least a couple should try to conceive for 1 year without using any contraception. The important thing is, this is when we don't know anything about the background of female or male partner. Of course, if we already knew about their medical background, we don't need to wait for 1 year. But this is kind of general rule that because we don't expect that very quickly everyone can conceive, even if they are completely normal. And infertility could be either primary or secondary. What's the meaning of this? If none of the couple, the partners of a couple as a unit had a pregnancy history in their life in any relationship, then we call it primary. And if at least one of them had some history in past, either in current relationship or another relationship, we call it secondary, because that gives us a lot of information when we are evaluating this couples or a person. I know in my practice that even many physicians, when you're not in the field of infertility, they don't have good idea about infertility prevalence, how much it's common in our community or everywhere. Then I can imagine that the people not in the medical field may not have a good idea about this. And one of the reasons is usually people, they do not share their infertility problem with other people. It's kind of taboo. That's why many people, they don't know. But it's really interesting if you know how common is infertility. We know that in general in the United States, 1 out of every 6 couples, they deal with infertility problem. And it could be even higher in some areas or some other countries. About the reason and the cause and etiology of infertility, there's some data, but in general, we know that in 50% of the time, there's something wrong in the female partner, and 30% it's only on male, and 20% it's in both. There's some data actually that recently support this, even it becomes more on male part. Even some researchers, they believe that it became almost 50-50. And of course, there are some cases that we don't know really the problem it's on male or female, because the current medicine cannot find any reason for the problem. And in general, around 8 million people currently in the United States, they are dealing with kind of infertility problem. As you see, it's very common for the whole population. And of course, it should have different grades, and as you remember, it's not only one person, it's a combination of 2 persons, and depends on how is the situation of, reproductive system and fertility ability of each of the partner. This could be more complicated or, based on the evaluation. And this is a nice diagram, shows that, actually, I can tell you that if there is a problem in both, 1 + 1 is more than 2. And it's actually become even more complicated. And of course, the role of medical people and the physician to help and find this as a team, as I told you, focusing on both is very important. For the male infertility, of course, the genital system is a system that, first of all, we think about anything related to the fertility, but we should know that there is a communication between the brain system and the glands around this brain, especially the pituitary gland, and the genital system in male, which, I mean, both testicles, the tubing system that connect the testicle to the outside, and the system that we call it ejaculation system, and all the glands related to this to provide the semen at the time of sexual activity. Any problem in any part of this could make the person infertile. That's the way we call actually the infertility problem in different stage. We can say that the problem could be before testicles, which mainly will be in the brain system and the system that control the genital area. It could be on the testicles, or it could be after testicle. This is kind of general, classification. And as probably you can see in these pictures, for example, for the Klinefelter syndrome that we will focus on it, the main problem focused on the testicles, not before or after that. Here in this table, you can see actually a kind of percentage of different reasons for male infertility. Of course, there's no time to go through all of them, and that's not our interest tonight, but it's good to see that around 8% of the problem is kind of genetics. When we are talking about X and Y variation, of course, our talk is about genetic, and you see that it's the big part of this different categories. When we are talking about a man and see how is the fertility, of course we are talking about a person who is after the age of puberty. It's looking at the semen and see if he has any sperm. I would like to say that every boy, when he was born, he doesn't have any sperm, and the sperm production usually start after puberty. And that's the age that could be different in different people, different area, but kind of average of 10 to 12-year-old. It's the age we expect. When it's possible to check, the first thing should be just check if there's any sperm and how they look in the semen, in the ejaculate. There are some important things about the abstinence time, which means the last time that the person ejaculated before collecting the samples. The technique is very important because we know that the first part of the ejaculation has more sperm. If there is a sperm, then the person should try to collect the entire sample. If for some reason lost part of it, simply we tell the person just wait for another time and then you can repeat it. And very important, if one test is not normal, we never just focused on that one. We have to repeat it, not immediately after a couple of weeks. And there are a lot of numbers to evaluate the sperms in the ejaculate. And again, there's some agreement based on the World Health Organization and the reference value. You can see here that the numbers actually from 1980 till 2010, which is the last time, for the volume, for the number of sperm, for the percentage of the sperm that they are motile as a normal value change over time. And this column actually show the latest one, and you see that a normal man in general should have more than 15 million sperm in every milliliter of his ejaculate. And of course, this number fluctuating. This is a nice graph. A couple of years ago, a researcher actually asked one of his technicians who had children to provide semen samples for almost 2 years every week. And you can see that there is a fluctuation on the number of sperm because a lot of things like stress, other disease, medication, and a lot of things that even we don't know can affect this number. That's one of the reasons when one time the test is not normal, we would like to repeat it, not immediately. In a couple of weeks when the person is in different situations. When we move to the female, it's more complicated. Again, the system, it's the connection between the brain and the pituitary gland, especially there. And of course, you know, equal to the testicles in women, we have the ovaries, which there are 2 ovaries, and they're responsible to make, you know, the eggs and the hormones, the female hormones. And of course, there's a uterus, there's a tubing system that connecting the ovary to the uterus. And of course, why the sperm should be able to move, because after sexual activity, they go up to meet an egg, which you can see as a cartoon here, that couple of sperm, they are meeting an egg, which was released from ovary. They make the embryo, and the embryo comes a little down to the uterus to implant it, and the pregnancy, this happens. Any part of this system, if has some problem, you know, the person may have infertility problem as a female. Again, there are different, you know, etiology causes that can make infertility in female. It could be some problem in ovulation, could be the aging, could be depend on the reservation of each ovary. And remember here, this terminology, we will talk later about it, which call it premature ovarian failure, which means to become menopause earlier than the average of the population. And it could be other hormonal or other things. It could be some problem in the tubing system I just show you connecting the system, or it could be the problem in the uterine or cervical, which, you know, again, we don't have time to discuss all of this, but it's good to have an idea about this. And you can see here the percentage of different, and you see the big part is related to ovulation, which means making and provide, you know, releasing the eggs. Of course, tonight, you know, we want to focus on very specific groups, and we will focus on a group that the axis actually is trying to support. For the male, the most common is the people that they have extra X, or they have extra egg as a male, or extra X and Y. And of course, for female, the people that they have extra X or triple X. This table actually can give you an idea about different genetic abnormality, you know, and the incidence of each one. And as you see here, if you look at the most actually common abnormality in the number of chromosome is related to X and Y. You can see in other parts, you know, some abnormality in chromosome number 21, 13, 18. They're not as common as they are either as in female or male. And that's why we need kind of association like axis that should help this kind of variation. And it's actually very true. I learned from a lot of families that we should call them more than just a patient, a variation, because they're very common. And if we can help them, they should be fine in their life. When we are talking about the chromosomes, this is actually a pictures that when we look at the chromosome of a person, we get from our lab, you know. They count the number of chromosomes in every human cell, and you can see here that every human as a male has 46 chromosomes, that 22 of them as a pair, they are non-sex chromosome that we call them somatic chromosome, and 2 of them actually are the sex chromosome, that one is X and the other one Y. The Y chromosome is much smaller than the X. Long time ago, actually, coming back to 1942, a physician whose last name was Klinefelter, Dr. Klinefelter, he described for the first time a patient who has endocrine problem that couple of years later, when they were able to do more genetics in the lab, they could find that the person has extra X chromosome. And that's the way they used his name and put on this genetics syndrome. And it's used for many years as Klinefelter. You already know how common is Klinefelter. As you see, it could be as common as 1 out of 500 new born male. And this is the most common sex chromosome disorder in men, and also it's the most common genetic cause of male infertility. And even more important, many genetics problems, they actually have a problem to survive, but for Klinefelter, most of these patients, they have the same life expectancy as the general population. And that makes it even more important to focus on this patient or this individuals with the X and Y variation. How it happens? Most of the time, the father or mother of a Klinefelter patients does not have any genetics problem. What happened, you remember the sperms or the eggs that they should meet each other and make the embryo. It could be that the sperms from father, instead of having only one X or one Y, has X and Y. Or the egg from mom, instead of having only one X, has two X. And that happened as an error, and the embryo will be XY, or, you know, it could be also other variation, which we will talk to. 80 to 90% are XXY, which means they have one extra chromosome. But we do see other people, you know, sometimes there's a name for them, but we look at them in general under the name of Klinefelter because they share a lot of similarity, and that they may have even 48 or 49. And there are people that there is a mosaicism, which means they have a mixture of normal chromosome cells and abnormal. They could have some cells that, you know, are normal, and some other cells, they have the extra sex chromosome. And, you know, and it could be a structural problem on X chromosome that sometimes they can also find it on karyotype. These days, actually, they're very good by using software even to tell us about some defect on the chromosome before we do more molecular tests. The thing is, we see this variation, we try to put them in different category, but actually, in our experience, we see a lot of variation even in each category. What we call it classic, really it's not classic, because even the people with the 47 XXY from one person could be different to another person in different aspects. What is important in this patient different to, you know, the normal male? You know, you remember I show you a male has testicles that produce testosterone and is responsible to make a sperm after puberty. In these people, the testosterone levels usually is normal because every boy has a very low level of testosterone even after he was born. And when we compare this as an infant or even before puberty, the level is very, very similar to the normal, you know, genetics boys. Most of the boys, they initiate even puberty normally, the same as, you know, and as I told you, even in people without any X and Y variation, we don't see exactly in a specific age. It could be different from one family to another family or from one area to another area that people they live. But we see that, some of them, they have early puberty or delayed puberty, but in general, when we look at many of them, they have almost or starting the normal puberty. But the problem actually starts from that point, that the progress is not as much as we expect normally, and it will be fail. The testosterone level start increasing, and then there will be a plateau, and then even it goes down in mid-puberty. This is kind of a graph. It's kind of complicated, but can give you actually, just to have an idea, you remember there's some communication from the brain area, pituitary gland, which they produce FSH and LH hormone, and of course testosterone, which is produced by testosterone. And in each part, there are 3 parts here from left to side. You can see the normal 46XY, just the normal male, to compare with Klinefelter. You see that there are more FSH and LH, from this, which means the glands are pushing testicle to work harder. And when we look at the testosterone, the level in average is less in the 47, which means even they're more pushing on testicle to work, but they work less. That's the failure that happened in these people. On the other hand, I told you that the sperm production is another function of the testis, and each testicle actually contains of 400 very long tubes, which we call them seminiferous tubules. We cannot see it really by eye. We need to look at under the microscope. And inside of each of these, the sperm production happened. And as I told you, this happened after puberty. In these people, which usually, in a normal male, most of the tubes, when there is no problem, they're making the sperm. Not 100%, but most of them. But in these people, if they make a sperm, which we will talk about, what's the chance that they make a sperm, it happens in just few of these tubes, not everywhere. It's rare, but it may happen. And interestingly, when they make a sperm, the sperms are normal. That's why if we look at the sperms from a Klinefelter person, in genetics part, you remember a sperm should have normally only one X or one Y. It's almost the same in a Klinefelter. That's amazing, the system. It looks that the body can correct this. And then when there is a sperm, the sperm is most of the time as normal as it is in a normal male. I mentioned that the testicular function is not as great as it was, and of course we expect that the size of testicle change, when the boy is older. This is a tool that we use actually to measure the testicles in patients. We call it archeometer. This is actually a combination of some testicular type things, which you can see the small testes in a childhood, and it will be bigger and bigger, gradually, mainly, after puberty, the size increased. And that's the way we can see what happening, the Klinefelter people, as I mentioned, because of the problem that starts after puberty, the size of testicle is not really increasing. That's why even if we see older patients, most of them, they have a size of testicle like an early puberty person. And historically, we could not recognize these people, but today many pediatricians, they know about this. They examine, and they should examine the boys, and they can figure out earlier, at least around puberty or after that it's likely that the person is dealing with this variation. And this is one of the most important things. And the puberty time is very critical in this people, because this is the time that the testicular function is failed, and and the person needs some help. And one of the big help is, because every man needs testosterone, many physicians, especially in the field of endocrine pediatrician, they will try to help the patient and give him testosterone. Also, this is an important time that, we should think about fertility and have a plan for these people. Why testosterone replacement or testosterone therapy is important in these patients? Because of different reasons. Testosterone, it's not only for sexual activity, actually it has a lot of function. It promotes the general growth of the boy, help him to have more muscle mass, a stronger mass like a man, helps to have a strong bone density and good bones, and also, of course, for developing the sexual characteristic as a boy, it's very important. And it has also, we know that positive psychological benefits. If it's low, the patient may deal with some of the psychological. And of course, if we increase it for older people, I'm not talking about the young boys, it helps, when the person starts sexual activity, it helps having better libido, interest for the sex, and also better erection function. But we should aware of something. Testosterone is important, but if the person gets the testosterone from outside the body by prescribing either as a gel or injection, and when it's prescribed for a long term, which you can imagine for people that start around puberty for many years, they should be on it, that may work like a contraception. And this effect in some people could be irreversible. It's not easy to stop testosterone and come back to a normal situation. And the simple way is, it's like you provide free money to someone for a very, very long term. He or she becomes very, lazy, doesn't want to work, and even if wants to start work, will be very hard. That's the same for the testicle. They became lazy, they shrink, and if it's a very long term, I'm not talking about the short term, which there could be some advantage, some cases, then this will be very important. Unfortunately, we see this one not only on Klinefelter, on other people that are physicians, they're not aware of this, put the patient, or they know it, they forgot to discuss with the patient, and then the patient will have more problem in the future when he stops testosterone. That's something that should be considered. There are some alternative for this. There are some medication, either in a type of injection or just the oral pill, that not in all, but in some patients, depends on how is the, the level of the endocrine system, could help these patients to push their testicle to make more testosterone before we put them on long-term testosterone, which for every patient could be different and needs to be evaluated and decide a good plan. As I mentioned to you, the puberty time is a time, it's an important time to think about fertility in the future. But actually, this is what we do in our practice, and we believe it should be done. We are open to consult anyone, and we see actually patients that even before pregnancy, they come to us. For example, they went through an IVF, they create embryo, frozen, they have some embryo that genetics shows that it's the Klinefelter. They want to know what to do about this. And one of the aspects is the fertility, which we are ready to, and we are available to consult them. We see some pregnant women or get a call that, they want to learn about this to see what they should do with the baby. And of course, when the baby is born, that's a time that, usually if they refer to us, we give them some consultation. And usually in our pediatric setting, we would like to see the patient just following his growths and some non-invasive, evaluation every year. And of course, when we are closer to the puberty, this will be much more important. This doesn't mean that if we see a patient in an older age, we are not able to help. But of course, this time, we are able to diagnose earlier, then of course we can help this kind of patient for any aspect, including infertility, if we know it in advance. And of course, there are options for this to preserve their fertility, that some of them are clinically available and some of them are experimental. We will talk later about those in details. What we do when we have a boy in any age, we check about his level of sexual maturity, which we have a staging that simply in a cartoon you can see. We look at the size of the testicle, we look at the pubic hair, the size of the penis, and of course it's not applicable 100% on Klinefelter, because you remember that on if it's a Klinefelter, we don't expect, the growth of the testicles as much as we see in other. But anyway, this is the way we check, and we look at different things, and then we can have an idea about the level of the sexual maturity of the person, in addition to extra blood test and the level of the endocrine, which we talk about it. In our setting, we had a chance to work closely with our radiologists and have a system that, we can actually monitor in a very non-invasive system. You're all familiar with the ultrasound. The ultrasound system, it's a non-invasive, just put some jelly and a probe and imaging. And this system that it's available in our setting, and it should be available in other systems, we call it elasto ultrasound, which actually will able to measure in somehow what's going on inside the testicle, because we know that the stiffness of the testis, because of the dysfunction and the fibrosis happen in these people, actually increase over time. But it's very hard just by doing a physical examination. This is a tool that we can actually, in each person, can measure it easily and see what's the difference to compare to the last year, or in some cases around the puberty, we may need to do it even earlier, every 6 months, to see the difference and decide what's the time that we should do any, procedure or more serious application with the patients. This is kind of, diagram shows that in general, based on the age of the patients and the level of the puberty, I show you the scaling we have. And that a person can think about fertility. Of course, you remember the easiest way to evaluate, and of course, it's collecting the semen if it's possible, which is usually difficult for younger boys. It's getting the semen and look at, and if there's a sperm, we freeze it before putting the patient on any treatment. We know and we understand that many of the boys, for many reasons, are not able to do this one. That's why in our setting, we try to have something before going to the more invasive steps. And there is a system that actually we can use it to collect the semen and check about the sperm. We call it electroejaculation. The name looks a little scary, but it's a very safe system. And we use it, and we expect actually to get semen with the sperm when, as you see in this diagram, the person has at least the level 3 of or sexual, scaling, the Tanner scale. And that's kind of give us some idea, plus other evaluation to find a good. It's not only the age. We should look at actually overall on all of this and decide. But when we decided, and for some reason the person is not able, then we use this system, which was developed by Professor Seeger for actually initially the people with ejaculation problem, but no, there are the probes available for kids. And of course, this should be done when the kid is under the sedation. It's something that he should not feel it. And we combine it with our setting as a one-step, fertility preservation when, we expect that the chance that there is a sperm and that there is any sperm in the ejaculate is very low, which actually it is in most of the Klinefelter patients. Then we put the patient in this on sedation, and if we get the semen, we pass it to our embryologist and looking at immediately, and if there's no sperm, then we can go to the next step when the patient is sleeping under the anesthesia. And that actually looking at inside the testicle, you remember I told you that there are very tiny tubes that in these patients, there is a chance that in some area, the sperm production happens. And because we are not able to see this just by human eye, we need actually to use a very sensitive microscope for surgery and looking at area. This is an example of one of the patients that, you see a lot of tiny tubes, but we found an area that the tubes are thicker, which give us more chance that there is a sperm, and we give samples to the embryologist to check immediately about the sperm, and if he found or she found more, then we can have more from that area and freeze. And remember that, this kind of sperm, if they are almost the same as normal sperm in the normal people. What can we do with this sperm? The way we can use it, we can freeze it almost forever. The sperms are very stable. It's not something that we are worried to use them in a couple of years. Actually, there's a data to use frozen sperm even after 25 years with no problem for fertilization. And of course, the in vitro fertilization, which started around 30 years ago, was a revolution for many patients, including these patients. And for people that they didn't heard about it or they want to know, it's a way that the egg is collecting from the female partner, the sperm from the man, and then put them together in a dish, grow them for a couple of days out of the body, and then transfer to the female partner body. And the new system, which it's actually just selecting one sperm and injecting to the egg, which you see in this video. It's called intracytoplasmic sperm injection, which was started in 1991 and 92 in Belgium, which was a huge advantage for many patients that, they don't have any sperm that can move, but still, we are able to help them to inject one sperm, select it to the egg, and make the embryo and the pregnancy happen after transfer. The chance to find a sperm in the Klinefelter patients, there are a lot of data. The people try to put this data together. Unfortunately, there is no multi-center study that, it's under the control, but by just gathering the data from different groups, we can say that there is around 44% chance to find a sperm in this, if it's under the good, setting, having all this system that I described for you. And there is a 43%, chance of live birth per ICSI cycle, because, we may be able to get the sperm and use it when they need to create embryo, and we can freeze this embryo. But in each cycle, that we try to get, the chance is 43%. And by repeating these cycles, the chance could be even higher. That's actually great hopes for many of these patients, and they can go through it. I mentioned to you that the sperms are usually normal, but it's really recommended that, we should be careful, because we don't know the variation between different people. And what we recommend is using a technique called pre-implantation genetic diagnosis. You remember the egg and the sperm when it was injected to the egg. This is an embryo after around 4 to 5 days with multiple cells, and this is a technique that the embryologist can easily, without hurting the embryo, remove one or sometimes more than one cells and send these single cells to the specific genetic lab and freeze the embryo and wait for the result. In some setting, they do it quickly and keep the embryo fresh, but most of the centers, they try not to do it fresh to be sure about the diagnostic. And then, for example, a patient has 10 embryo, they come back with the result, and then they can choose each embryo is normal, which one is male, which one is female, and then the couple can decide to start using which one for embryo transfer. Of course, PGD and pre-implantation genetic disease needs just one webinar to talk about different techniques, different indication, which is not our focus, but I will be happy to answer some question that maybe people has on this. I told you that 44% of the people, there is a chance in 44% that we find a sperm. What about when there's no sperm? Of course, the risk of 56% at least, the failure to find a sperm is not low. That's why, when there's no sperm, which I told you when a boy is born, he doesn't have a sperm. The sperm production starts after puberty. What he has the cells that, he has them before puberty and just after he was born, and we call them spermatogonial stem cells, and they are important to change to the sperm after that. There are not a lot of studies, but based on what we learned from the animal study plus limited human study, the chance that we can find and get these stem cells in Klinefelter patient in earlier age is higher than older. And why it's important? These stem cells, as I told you, they are located in the testes and they go through a differentiation to make one sperm. And why it's important? Because, if a boy does not have any sperm when we are operating or we are trying to find a sperm, but still he has stem cells, we may be able to use these stem cells based on what the science is going forward and make a sperm out of it by even to make it in a dish. And then, of course, if we can make the sperm by differentiating these stem cells to the sperm, that can be used for IVF. Or there is another hope that if we can increase the number of these stem cells and put it back to the patient, maybe they start, to make more sperm. And this process, not specifically on Klinefelter, but in general, I mean, in different models, has been done in animals, including monkeys, and it worked. That's why it's a big hope for, these patients who also the stem cell technology can help them. But of course, we know that earlier age is higher chance, and if we get it, and we hope, first of all, we can find a sperm, but if not, give them a big hope. But this process is still experimental. Ethically, we are not able to tell the patient that, this is something that clinically we can provide to you. It's still experimental. We need to start, and there are a lot of steps before we can try it on human. That's why we developed a banking system, experimental banking for different type of patients, including the Klinefelter patients, that we preserve this as their stem cells with the potential used in the future after the process simply I explained to you, and reproduce or start the sperm production. So far, the banking system that we started in our institute we offered, to more than 130 patients, and around 70% of them, for different reasons, when they went through a testicular biopsy, in this case for the Klinefelter patients, when they were eligible to go through the surgery, microsurgery, to find a sperm, either if we find a sperm or not, we offer them to get a small tissue for the stem cell part and keep it for them for the future. Of course, if they found a sperm, they have IVF option, which is great for them. But even if they have that one, the idea have the stem cells increasing, put it back, and maybe they don't need the IVF. It's great for them, give them another chance. That's why, we offer this. There's no cost for getting these stem cells and, keep it, and no maintenance storage for this right now, because it still is experimental. And of course, if they are in a percentage that there is no sperm, unfortunately, this is the only chance. But still, this is free. That means that they went through a clinical procedure to figure out if they have a sperm or not. They freeze it, and for that part, they are responsible, financially for the cost. But for the stem cell part, as a bonus, based on the institutional review board and the consent form we have, this provided for free, and we hope that can help many of these patients in the future. Now we move to female, which this is again a karyotyping, counting the chromosomes. You see, normal female has 2 X chromosome, and the same for non-sex chromosome. There are people that they have extra X chromosome, and that's the triple X. And I already show you how much is common. It's also very common. The history is actually in 1959, the first time there was a person that in Scotland, in Europe, that was described in the age of 35-year-old, a tall person who parents that they had pregnancy when they were at the age of 41 and 40, and she was dealing with to become menopause earlier age, which we will talk about it. And this is usually happens based on the data we have in the older parents, but it's not always the case, of course, but the risk is higher that this happens. How much is common? Around 1 in 1,000, a little less common than Klinefelter, but it still is very common. Most, this is the most common sex chromosome abnormality in females, like Klinefelter in male. And, most of them, there's no diagnosis for this, and just by accident, it has been done, because actually they look very normal, this kind of people. And there is a, believe that they are usually higher than normal, but we see a lot of high people in this country. Sometimes it's hard to say, and many times the parents are high. There is some idea that they should be higher, but not always again. The point is, most of the time, these patients, they do not have any problem with the puberty and fertility. And they are almost in the normal range, which again, the puberty could be different in different people, different families, for the female too. But we know that there is a higher risk of dealing with premature ovarian failure. What is premature ovarian failure? A normal ovary, usually works between the age of 18, and 45. It starts earlier, but I mean, that's the reproductive age. And, after the age of 45, it's the time that the regular cycles become irregular, and then eventually the cycle will stop. But if this happened earlier, which could happen as early as the age of sometimes 20, We call it premature ovarian failure. And this is something that we should pay attention on this, patient, because it's important for their life and also for their fertility. In general population, this disorder happens in 1% of the women. Unfortunately, there's not enough data to provide a number for triple X, but there are some data that says it's more. But when it's more, it doesn't mean that it's a huge difference. The risk is higher, which means that, as you see, they say it's somewhat, more common. And that's why it's good if we know about this and the diagnosis happened for other reason. It's good to get a good care and to be aware of this, because there's some way again that this patient can have just the annual visit and check, and if it's in a risk, there's some option that they can think about it before, and especially before waiting for the long term, because in general population right now the age of pregnancy is higher, then that could be important for this group of patients too. Then the good news again is, even many when a woman, a girl, is dealing with the triple X, her egg are not abnormal. Remember the sperm? The same things happened for the X. The good thing is the risk of having abnormal offspring, the baby out of a mother with the triple X, is not higher than general population. And that's actually, it's very important to know, because then that's also one of the reasons that we are not aware of many of these patients. Kind of summary of what we discussed tonight. Infertility is common in the population as around 15%, but when we go to the Klinefelter patients, it's go even around 98% or more. Early fertility preservation is recommended before long-term testosterone replacement, and we talk about the reason and the way we should think about this. Today, using the microsurgical testicular sperm extraction and combination with the ICSI, as actually is this successful clinical option available for these patients, that they will be able to have their own biological genetics children. Of course, the spermatogonial stem cell technology, it's a great hope for the future, and there are some way, as I explained to you, like OR setting, that we can actually have more hope to help this patient. And for the triple X, as we learned, we don't have the same problem as the X and Y variation in men, fortunately. Most of them, they're not dealing with the infertility, but we should be aware of the, somehow some higher risk of primary ovarian failure, which it will be easy to manage by a subspecialist in this field, and give a good advice to the patient to either, try to have children earlier or preserve some, eggs or tissue before, dealing with this problem. Our team, which you learned from Dr. Kogan and I tonight, and we have the third person, Dr. Stuart Howard, which is not with us tonight. Actually, we are working on the male patients, but as I mentioned to you initially, we are working closely together with a team that, part of our team are reproductive endocrinologists for infertility, the gynecologists that are subspecialists on female part, and we approach together and we help male and female patients too. This was my presentation. This is the contact number if you want to contact us. for any question, or get more information in any way we can help, or send us the information. This is a direct phone number, direct fax number that you can have it. And I think this is a great time to look at the question we have, and hopefully with help of Dr. Kogan, we can actually answer the question together. Probably Dr. Kogan wants to start, but first, Robbie.
Yeah, let me interject just for a moment. We had somebody ask again for instructions on how to ask questions, so I'm going to have our webinar manager jump in case people are having trouble seeing how to answer questions. So, Rick, can you give a clarification?
Certainly. So towards the bottom of the GoToWebinar control panel, you should see a little tab that says questions, and below that a box where you can enter text. And yeah, you just go ahead and type your question in there and hit the send button, and then that'll pop up for us to see.
Thank you, Rick. So, Dr. Sadri and Dr. Kogan, I know you're seeing the questions too, and I thought you might want to kind of look them over. I know there are some of the questions, by the way, had to do with technical problems people were having, so you could skip over those. But anything that you could say about some of these questions would be, I'm sure, most appreciated.
Sure. Dr. Kogan, you want to start, or you want me start from the question and you help for the answer?
I'm happy to address the first question,
Sure.
which for those that may or may not be able to see it is, would you recommend a testicular biopsy in a 12 to 13-year-old boy with XXY chromosome analysis Klinefelter syndrome? And as a way, and also the question relates to collecting sperm to freeze for fertility preservation. We, as Dr. Sadri indicated earlier, we like to start in a much simpler, non-invasive way. And what I mean by that is that the direct answer to this question is we need to know his pubertal status and his capability of ejaculating and potentially producing sperm. That would be the initial step. If he was unable to ejaculate, unwilling or unable, or he was unable, based on his pubertal status, to potentially produce sperm, then we have the option in the first case to perform an electroejaculation, which in some ways, again, depending on his pubertal stage, would be successful even though he couldn't ejaculate. And then we, in our single encounter arrangement for fertility evaluation and treatment, we would then have the embryologist look at the ejaculate and see if there were sperm present. If there are sperm present, then we all applaud and we say the job is done and the sperm can be frozen and preserved for later fertility use. If there are no sperm in the ejaculate, we then could go right on and do microsurgical testicular sperm extraction, because as Dr. Sadri indicated, and as we in research have really come to understand, the stem cells, the reserve cells, have a great potential based on the technology that is evolving rapidly presently to be preserved and then matured in the dish or retransplanted back into the infertile older male if it's appropriate later in life. So that's a rather long-winded answer to your question. Should the sperm collection be done before testosterone supplementation begins? We have a strong inclination that testosterone supplementation should not be started until the fertility aspect is addressed. And with our pediatric endocrinologists, we work closely together in individualizing these decisions in each particular boy. So I hope that answers your question.
Another question we got about a family with a child with a 40XXXYY. They ask if the same options for the classic Klinefelter is available for these patients. The answer is yes. You know, the approach is the same, and you know, there should be the same chance. Of course, we do some evaluation on some molecular evaluation before we try for any invasive procedure to have kind of estimation about the chance to find a sperm. But the answer is yes, they could get benefit as the other, you know, the classic Klinefelter 47XY, they can get it. It could be, you know, the chance of finding a sperm less. There are not a lot of data because this kind of patients are not as common as the classic 47XXY. Do you want to go for another question, Dr. Kogan?
Well, I see that the questions, the subsequent questions now mostly pertain to the older patient and relate to stem cell storage and so on, more on the experimental side, and maybe you should address that one. Are there options for stem cell storage and making eggs for women the way that we use stem cell storage to make sperm for men? We have some information on that, but Hooman, why don't you address that?
Yeah, you know, the field on having the egg and, you know, and freeze it, it's, you know, or even having the ovary and grafting, it's, especially this part is more advanced in female. For testes, you know, still is more experimental, although both of them for using the ovary tissue and testes are experimental, but you know, there's some similarity between these two, but some differences too. For the female, if I understood exactly the question, if they're asking about the XXX, you know, in case that, you know, they are at risk and they have some sign of premature ovarian failure, based on other cases, it's possible to preserve ovary for the future. Or even, I think I saw in one of the questions that one of the family mentioned they tried and they got, with some difficulty, the eggs, you know, from their daughter and frozen in a very early age. Of course, this should be used in the future in any way. I saw another question. They ask if the testicular tissue banking that I mentioned at Wake Forest is the only one in United States. There are at least two other, you know, experimental testicular tissue banking in United States officially as a program, which they offer to cancer patients. As far as I know, right now we are the only place that we offer it to keep stem cells. But I know that other centers, they are trying to have this as an option, and I hope it will be available. And we are working also to provide some facility to work with other centers too. But the good thing is for cancer patients and this kind of banking, there's urgency to start, you know, the chemo radiation before, you know, hurting the stem cells. But fortunately for Klinefelter patients, we don't have this urgency and they can refer to other centers too.
I see a question here that says, I have a son with Klinefelters. Can he be considered for the fertility research? If so, who do we contact? I want to just stop for a moment and say that yes, we do fertility research, but we don't lose sight of the fact that we're doing this for the benefit of your son, the individual. So both, we want to help your son in any ways that, based on the knowledge and the research we have generated, that would be helpful for him. And as a side part of that, he can be a part of the fertility research that goes on. But I would rather emphasize here that not the research, but the help that can be provided for your son.
Sure. And actually, I would like to say something. I put, my contact information here. The direct phone you see, it's really direct. If you call this number, either I answer or you leave a message, which I get it directly, and I will try to call you back, especially for the parents and the patient that you're far from us. We will be happy, to have them and contact them to discuss over the phone, because every case could be different, and then we will see how we can help them. And many cases we can start actually by contacting with their primary doctor to do some primary evaluation before really we need them to come down to us. That's the way we provide this service, and we hope that we can help more patients in this way. I think that helps because probably we are not able to answer all the questions in details, and some question could be very personal or specific for a special case. I see another question here. They ask if the microtesticular sperm extraction is covered by insurance. This is a very good question. Unfortunately, many states, their regulation actually does not cover infertility treatment, and many private insurance, especially, they do not cover. This procedure, it's a couple of hours procedures, which usually at least we need 2 specialists operating together. We need to have a team as embryologists in our setting, and it could be very expensive, in any service. What we were able to do is we could get kind of a special, price for the Klinefelter patients that, our institute can help this patient. But of course, this may change. I don't want to really mention about the number, but when the patient contact, we refer them to the financial part. They can discuss with them. And that doesn't mean that even if the patient has an insurance, is not able to reimburse it from the insurance. But the system, it's kind of discounted rate with a special price, but everything is unfortunately based on cash, but they can actually get the information, and if they have a special insurance cover. But in general, unfortunately, infertility treatment is not covered by insurance. That was one of the questions.
Hooman,
go ahead, finish, Dr. Kogan.
I see a number of questions related to the issue of when to start testosterone, and some that relate to their children actually having started testosterone and what to do then. There is a balance between the need and the desire to initiate puberty, and that certainly is an important step. The challenge is how to interrelate that with the need to do the best to optimize your child's fertility status in the future, or potential for fertility. As a generalization, we recommend having a fertility consultation before starting testosterone treatment. There's a number of different variables that I mentioned that enter into the decisions about when and how to optimize fertility. We look at a number of things. Dr. Sadri had mentioned the special elastography evaluation of the testicle, hormonal levels, pubertal stage, and so on. So it's not possible to answer specifically for any one patient without knowing the specific information. However, as a generalization, when possible, we recommend having a fertility evaluation prior to starting testosterone. Dr. Sadri, do you want to add anything to that?
No, I agree with this. But Robbie, you want to mention something? I think Robbie was.
Yeah, well, I received an email question, which is sperm retrieval an option when a male with Klinefelter syndrome is age 44?
Yeah, as I mentioned, in any age, we can try to help. There's some data that earlier is better, but that doesn't mean that the person with that age doesn't have a chance. Of course, depend on how long he was on testosterone, because not all actually Klinefelter patients, they need to get testosterone. And I'm not sure in this question it's mentioned if he was on testosterone for a long term or not. And even if he was,
No.
yeah, there's no contraindication. There could be, and we have to, probably do some evaluation before that to have an idea. But the answer is not, never is late.
Dr. Sadri, I noticed you've been so kind also to provide your email address so that anybody tonight who did not get their question answered, sounds like you're comfortable with having them reach out to you through email.
Sure. I don't know if we have a few more minutes or we can.
We do, and I also want to answer another question that's come in a couple times, is that we do record these webinars, and they are up on our website within 24 to 48 hours at genetic.org under the word library and a submenu called videos, and there you'll see then an option to go to webinars. So absolutely, we record all these for future listening. But please, yeah, we have about 5 minutes left. So if the two of you want to continue to answer questions, that would be wonderful.
Yeah, that was actually good because I saw a couple of people, they were asking about the slides to be emailed. I mean, they will be able to watch recorded, videos on, the voice and the slide. That was great that you mentioned. There are a lot of questions about the age of testosterone treatment, which age is the best to start. It's really different. I just mentioned some actually Klinefelter patients, they may need testosterone replacement even later in their age based on the level. It's not something that we can just mention one age and say this is the best time to do. It's really something very personal, and for each patient could be different. And even the way of getting testosterone could be different. There are some data, I believe your next webinar will be about testosterone replacement, but by one of our colleagues. I'm sure he's going to show his experience and the data, and probably can answer in that webinar because has more time focusing on treatment. But I can tell you that this is something that we really discuss about each patient as a team and decide the best time and the best strategy for the medical treatment.
I just received another email question, and I'll read it, and I'm not sure exactly what it means, but I'll let you may. And the question is simply, how many babies are born to Klinefelter patients? And do we know the answer to that?
It's a great question. Yeah, we know, of course, we don't know for everywhere. We know just the one that is reported. We don't have a central system that every center, report for specific patients. They report their data, but the way there's some meta-analysis that published, and it's actually worldwide so far by ICSI. It's as far as I remember, they put together, it's a couple of hundreds to 1,000 reported based on this, but I don't recall the exact number. But it's something that, you know, the good thing, it's more than just one report from one center. I believe there is a meta-analysis of around 30 centers worldwide that they reported, you know, the patient they had. And of course, not all of them, they go through the ICSI, but that's the one that they went, and they and the data is based on that.
Well, before we wrap up tonight's webinar, do the two of you have any concluding remarks you'd like to share?
I think for me, I will be happy to, you know, talk to any of these parents or the older patients if they have any question. I will try my best to answer the emails or, you know, a phone call as soon as I can, depending on the load. But I think this was great opportunity for us, and I really look forward to see a lot of these parents in the next, you know, biannual seminar that you have, which I was in one of them, and I learned a lot, I mean, from the parents too, and I appreciate this opportunity. Thank you.
I would add that since my involvement and exposure to the research side of things has been much more recent than Dr. Sadri's, as I have been a clinician treating these patients for years, and now have become more introduced to the research side, I can tell you how striking it is as to how rapidly the research is evolving regarding testicular tissue banking and maturing the banked tissue in the lab, and moving on now to the potential and the prospects for retransplantation in the appropriate individuals. The progress over the last three or 4 years has been mind-bogglingly quick, and that offers great prospects for anyone who is or has children involved with these genetic disorders.
Well, I want to thank the two of you, Dr. Sadri and Dr. Kogan, for taking an hour and a half of your time. And I think you're on East Coast time, so it's late there, and very, very appreciated. And also very appreciated all of you audience members being part of this Access webinar. And I think I'll conclude with just reading this message that just came in right this moment that says, thank you very much. It was an excellent program. And I concur with that. And again, thank you so much. And I wish everyone a good evening.
Good evening to you. Good night.
Good evening.